Welcome back to Thrani, I'm Joe B. Today we'll go over manual techniques and exercises to restore normal atlanto-occipital joint mechanics for reduction of forward head posture and pain relief. Let's dive in. Your atlanto-occipital joint is the joint formed by the occipital condyles and superior articular facets of C1 or the atlas. It is a bilateral symmetrical ellipsoid synovial joint which allows flexion and extension and side bending with conjunct rotation. Muscle imbalance from cervical extensor tightness and cervical flexor weakness can lead to a forward head posture. First, this results to the occipital condyles rolling posteriorly but sliding anteriorly and gets stuck there. Second, the superior cervical facets glide down and back and gets stuck there. And third, the inferior cervical facets of C1 glides up and forward and gets stuck there. This contributes to cervical hyperlordosis. This can bring about persistent forward head posture, pain at the back of the ear on both sides, and difficulty to perform a chin tuck or cervical retraction. The assessment for cervical hyperlordosis can either be through the occiput-to-wall test or through joint mobility assessment. In occiput-to-wall test, the patient is in standing with heels, buttock, and shoulders against the wall. From there, the patient is asked to do a chin tuck by the therapist. Normally, the occiput should touch the wall. If unable and the distance between the occiput and the wall is more than 2 centimeters, then the patient has a forward head posture that leads to a cervical hyperlordosis. This is if the patient does not have a thoracic kyphosis. To confirm that the limitation to cervical retraction or chin tuck from forward head posture or cervical hyperlordosis, then do the atlanto-occipital joint mobility assessment. The patient position is in supine with the top of the head on the edge of the table, arms at sides and legs uncrossed. The therapist is above the patient with the right hand on the occiput and the left hand first dorsal web space above the left ear. When the neck is passively rotated to the left, then flexed forward, you are assessing the left atlanto-occipital joint. Normal findings is to have a smooth motion with no limitation in neck flexion. Then assess the right side by passively rotating the neck to the right and flexing forward. Abnormal findings that indicate cervical hyperlordosis from the occipital condyles stuck rolled posteriorly but glided anteriorly will be that the neck rotation to the left and neck flexion from there will be limited, coupled with a possible existence of a jerky motion pattern. Same with the right side. To explain further, if you look at the bony landmark, and if the occipital condyles are deviated anteriorly, then rotating the neck 25 degrees to the right and flexing it forward will cause the occipital condyles to glide posteriorly, but because it's translated anteriorly, it would be limited in that range. The same when the neck is rotated to the left and flexed from there. To treat, it is a good idea to loosen up the suboccipital muscles first to allow optimum joint movement during mobilization techniques. Patient will be in supine with arms at sides, head in neutral, and legs uncrossed. The therapist will be at the head of the bed with the dominant side radial border of the forearm just above the C2 spinous process. That is to be at the suboccipital muscles and the forearm resting on the treatment table. The left fingers press on the forehead gently to the table while the right forearm pronates to provide a soft tissue traction and suboccipital muscle release. This position is held for 90 to 120 seconds. Since the occipital condyles are protruded forward through the atlantooccipital posterior roll and anterior glide, the goal is to encourage opposite motion, which is occipital condyle anterior roll and posterior glide, also known as cervical retraction. To attain this, the position of the therapist and the patient are the same. However, manual contact is such that the left hand holds the base of the occiput and the right hand cupping the mandible. You add a side bending to the left and rotation to the right component just to isolate the right atlanto-occipital joint. Then side bending to the right and rotation to the left isolates the left atlanto-occipital joint. A high-velocity, low-amplitude thrust, or an HV lat, is added to cause an atlanto-occipital distraction and stretching of the joint capsule. If you cannot do the high-velocity, low-amplitude thrust, then a gentle distraction can just be performed. The position for that is held for 3 reps, 30 seconds each. To maintain the joint mobility gained from the manual techniques, the patient is asked to perform chin tuck exercises in supine, then progress to seated, standing, and finally in prone, all to strengthen the deep cervical flexors. The exercise is held for 6 seconds hold for 10 reps each. Cervical flexion stretches with shoulder in 45-degree flexion can be added for 3 reps, 30 seconds each, to stretch the tight cervical extensors. If you like this video, please like, share, and comment. And for more therapy animations, please subscribe to Therani.